Hi, once again from Dental XP. And today you're in actually for that proverbial treat. Two uniquely talented brothers from Modena, Italy, who put together the, not just placing implants, but the aesthetics and longevity of implants into fresh extraction sites. Dr. Alessandro Agnini graduated from the University in Modena, but then spent time with Gianfranco Carnevali, Gianfranco De Febvre, then at the University of Bern, and also put together not only the prosthetics and essentially the periodontics, the surgical aspects, but also the restorative aspects, the restorative factors in implants. He was later joined by his brother, Dr. Andrea Agnini, who similarly went to the University of Modena and then kind of came across the ocean to the United States and spent time at NYU with fellow Dental XP teachers, Dr. Dennis Tarnow, Dr. Stephen Chu, Dr. Christian Stavert, Dr. Michael Grau, all at the university, and he's actually now a fellow there. He similarly does kind of everything, the surgical, the restorative, and they've now put it together for us so that we can understand all the factors that go into contemplating one of the clinical scenarios that we're faced in the day-to-day practice, an individual tooth in the aesthetic zone that has to be extracted and an implant placed. How exactly do we go about it? Do we do it immediate or delayed? That constant, opposing information that we have. And you'll see that these are individual clinical scenarios. So they put together not only, the individual surgical techniques, the different products, but also the biology of the system and how to apply each one of these, not as a cookbook, but with a diagnostic acumen, and then selecting what you'd like to utilize in the individual case. Really excited to welcome both Alessandro and Andrea back to Dental XP, and looking forward to hearing.
Thank you, Dr. Garber, for the kind introduction. It's always a pleasure and an honor being here, invited again from you and Dr. Maurice and Henry. And today the topic of our lecture is going to be the immediate implant placement in the fresh extraction socket in the aesthetic zone. And we are going to try to speak about the diagnostic, the surgical, and the restorative consideration. It's one of the hottest topics right now in dentistry, so we are going to try to give a general overview. And we tried to divide the presentation in 5 main parts, in 5 main key points. At the beginning, we are going to start with an introduction, then we are going to look over the diagnostic key guys, then we are going to look into the extraction socket classification. We are going to discuss a little bit an article and some of the data that we got. And at the end, we are going to try to give some future consideration and a take-off message. So, starting with our introduction, with our first point, we said immediate implant placement in the aesthetic zone, and usually it's just one single implant. But here we see a patient that needs more than one single implant. And this is a complex case. It's a case that needs a lot of evaluation, a lot of information that we have to collect, that we have to achieve in order to arrive to a correct diagnosis. And from that correct diagnosis, we can move on, and with all the therapies, with all the multidisciplinary approach that we have, we can give to this 62 years old patient a nice result, a nice aesthetic result, in where we can try to combine form, function, biology, and precision. That if we manage to work all of them in the right way, if we manage to think biologically, that is one of the most important things, we can achieve aesthetic. And one of the main important things is the follow-up. I mean, this works as to stay in the mouth for the longest as possible and has to be stable in the mouth of the patient. So this patient has a 4-year follow-up, and we can see that the white aesthetic and the pink aesthetic in this case are well interfaced. And in this kind of treatment plan, we are like, as we said, is a multidisciplinary treatment plan. We're going to work, it has been worked with implant, it has been worked with prosthetic, and we manage with the implant and with like the guided bone regeneration to give again a correct shape to this patient's maxilla. And since we are talking about implant and we are talking about teeth and we are talking about tissue, we said that tooth and we said that the white aesthetic and the pink aesthetic has to go along together. And so the planning of this case is really important. And as I was saying before, we have always to think biologically. And as we know from the literature, this table here is a table that helps us to think biologically even during the treatment plan process of the patients in order to at the end have a nice result. And so again, as I was saying, if everything is done properly, if the diagnosis is achieved correctly, if the treatment plan is done in a correct way, we can have a nice result. If the technician helps us with his work, we can have a follow-up, we can have a stable dimension work in the mouth of the patient, talking about the white aesthetics, so the teeth, and the pink aesthetics, so the tissue. And it's always important to have the black and white aesthetic with the X-rays. So, as I was saying before, we start with a complex case, and in the 80s, 10 years ago, we were talking about survival rates, survival criteria for implants. And right now, in 2010, 2011, since like the last 10 years, we are trying to change our mind, and we are trying to talking about success criteria. And since our topic today is talking about aesthetic area, I think that this is even more important to be underlined, because if we have a patient like this, that is a patient that came to in our office in 2002, and it was not like a huge rehabilitation like we just saw, but it just needed one single teeth to be redone. But this single tooth, it's really difficult. We will see that we will have to collect a lot of information, to think about it a lot in order to give him a proper treatment plan, and in order to arrive to the success criteria that has been showed by the literature, that can be, as I was saying before, the harmony of the restoration with the ideation structures, and as I was saying before, we need to have a stable bone volume and architecture, but the stability of the soft tissue again is really important. And of course, the harmony of the peri-implant tissue and last but not least, the aesthetic satisfaction of the patient. It's really important, because at the end, the patient wants to see the tooth, not the implant. So, getting into our topic today, every day when we are going to extract the tooth, we should think before extracting it, what we can do, what can we do, or what should we do. So basically, we have some options that the literature gave us after the tooth extraction. And those options are like the spontaneous healing, that less and less is going to leave it in a side, rich preservation, and immediate implantation. These are the three mainly options that we have. But in order to choose one of them, in order to decide what can we do for the patient, we always have to have a feedback, and this feedback is given to us by the literature. And of course, a lot of literature has been written on this topic, and a lot of article is written right now, is been written right now about this topic. And one of the main things that we have to point out is what happened after the tooth extraction. And Schropp in 2003 and Araujo in 2008, they talk about the reduction, the shrinkage that we have after the tooth extraction. And we are going to try to explain why later on. Then we were talking, the literature talks about the use of GBR membranes after the extraction that can preserve the shrinkage that Schropp was talking about in order to compare it to the spontaneous healing. So do something or do nothing. And Botticelli and Araujo, 2004, 2005, they are saying that after the immediate implant placement and a flap elevation, that's really a main point that we have to underline, a flap elevation, we have a mean buccal bone resorption of 56% that we have to expect. But again, I'm underlining the flap elevation. And then Chen is saying that we can reduce, it seems that we can reduce the horizontal bone resorption if we put some bone graft, some graft inside the socket. And also, we are talking about bone graft, but we are talking also about soft tissue graft. And Jung explained to us that there is a possibility using the soft tissue punch that we can have a biological and aesthetic integration of the graft into the local host tissue. So this is another thing that we have to consider. But most of all, we have to think biologically. We have to look back to the literature and we have to think biologically. And now let's see why these authors, that this is a literature review that, as I was saying, is like starting from Lekovich 1997, ending up with Schropp in 2003. They were all these authors were like taking out, extracting tooth, waiting 6 months, and then they were like studying, calculating the vertical change of the socket. But most of all, they were all of them, they were like evaluating the buccolingual changes. And here we see some like data that it's really like to underline, because first of all of these authors were opening a flap while they were removing the tooth and while they were doing the measurements. So they had the buccolingual changes that was high, because there was like 5.9 millimeters, that is Schropp, that is the main one, but all of them, they were like between 2 and 4 millimeters of changes, and this is a lot, and we have to think about it, and we have to try to avoid it, because if not, we cannot have a nice aesthetic result. And when we are talking about it, we have to think why, and because we have to know that everywhere we are working, the key point, the key words is blood supply. So we have to know, while we are working on the socket, especially in the aesthetic zone, what are the main blood supply, what is the main blood supply given from the tooth, from the ligament and from the endosteum, in the sense that when we extract the tooth, we know that even the periodontal ligament is going away. So already the 33% of the blood supply of this area is going away. And so we are left with the periosteum and with the endosteum. But if we are talking about aesthetic zone, we know that the buccal plate, the width of the buccal plate is not that much. Sometimes it's really thin, and it's difficult that in that area we have some blood supply also from the bone. So most of the time we can have just the periosteum as the main blood supply of all the area, and it's not a 33%, but it's like the 66% of the blood supply of the teeth that is going to be missed. And so, as I was saying, one of the main point is to look also and to consider the thickness of the buccal plate. And this work by Mariano Sanz and his group in Madrid is saying to us that we have to look carefully of what we are doing, and that, as we can see here in his data analysis, the 86% of the patient that he was treating in his study, they had like a width of the buccal plate that was less than 2 millimeters. And so this is something that has to make us reflect, that has to make us think about it. And so we should try to preserve as much as we can, all the time that we can, the periosteum. And the only way of preserving the periosteum is not opening a flap. So one of the key things that can be a difference between the data of the literature from Lekovich and from Schropp that we just saw, is probably not to open a flap. In fact, as I was saying now, Dr. Fickel, Christian Stapper, and Urzeler, they did a study. They did a study and they look at the dimensional changes of the alveolar ridge contour after different socket preservation technique. But in this article, they say that leaving the periosteum in place decreased the resorption rate of the extraction socket. And this is exactly what I was saying, because this is really important. The periosteum is the main blood supply of the area, and we have to leave it alone as much as we can. So after that, we have to think that we have different option, different possibility of placing an implant. And Amerle, in 2004, in his consensus conference, defined like 4 main type of implant placement. Of course, type 1 is immediate implant placement, so extraction and immediately place an implant, of course. Type 2, that is called early delayed implant placement, that is placing the implant 4 or 8 weeks after extraction. And all of this topic is really, we can find in the literature, the Boozer works, that is talking about this approach. And then we have the type 3, that is a delayed implant placement, so 8-16 weeks, and then the type 4, 16-20 weeks after the extraction of the tooth. So getting into our topic, when we can do an immediate, when we can do a delayed, but what does an immediate approach or a delayed approach change for us, but also for the patient? So let's go and have a look at the timeline of the delayed approach protocol. We can see here that, of course, day 1 we are going to extract the tooth. We are going to wait for the healing of the soft tissue, of the remodeling of the bone. Then after 3 months we're going to enter again, placing the implant, waiting other 3 months for the osseointegration, placing a temporary, using the temporary in order to sculpt the tissue, taking the final impression, and after 7th or 9th month, usually we are ready to deliver the crown to our patient. And this is the timeline of the immediate approach protocol. And we can see here that at day 1, differently of what was happening before, we can extract the tooth, we can place the implant, and if we achieve the correct and the proper initial stability, initial primer stability, we can place the temp. And after 3 months, we can take the soft tissue impression, we can take the final impression of the implant, and usually after 4-5 months, we can deliver the crown to our patient. So we see that there are differences for the patient and for us, even because we have to see less the patient and there is like less surgical part on the patient. And it's really important to know all of these things, to know the literature, because as Khan presented very well in Boston at the Quintessence meeting last year in this overview of the literature, the data are not so different. The survival rate is almost the same, the facial gingival loss is almost the same, the bone loss is a little bit different, and the papilla loss, of course, is more on the delayed approach and less in the immediate. And we are gonna see why. But the most important thing is to understand when to do one and when to do the other. And the only way of doing it is achieve the correct diagnosis. So collect all the information possible that we can, all the information that we can, and decide which is the correct written plan, which is the correct approach for the patient. So we were talking about immediate implant placement, so which benefit this approach gave to us, but gave also to the patient. Because as I was saying before, is a decreased number of surgical procedure, that of course it's a benefit for the patient, is a decreased treatment time, we can avoid the interim removable prosthesis, so we can try to improve the quality of the life of the patient even during the treatment plan, not just at the end. We can increase the patient comfort, as I was just saying, but one of the main important thing is that we can preserve, we can work better the soft tissue contour. And I can explain it very well here thanks to a slide that Dr. Cho, that was my faculty at NYU, gave to me, where we can see the differences between the papilla before the extraction, 10 minutes after extraction, 30 minutes, 2 hours after extraction, and 7 days at the follow-up. And we can see that immediately after extraction, 10 minutes after, the papilla is already going up, and 30 minutes is going up even more. And when we place the implant, if we achieve the correct implant stability, we can place the temp, and if the temp is done properly, because the temp has to be done properly, at the follow-up we can see that the same papilla is still there. Before the papilla that we had before of the extraction, we have the same level of the papilla after 7 days. But this is thanks to the fact that in this case we thought biologically. We thought about the literature, and we spent time on doing the correct emergence profile, the correct shape of the temporary. That it's really important, because every detail is important in this kind of approach. And as I was saying before, the papilla, the soft tissue, so we are talking about pink. We are talking about pink aesthetic. And Furhauser gave us like a sort of like table where we can like score our pink in our patient's mouth. So we have different kind of like how can I say, points that we can score and that we can arrive to give our pink score to our patient, like we did in the patient on the left. That is it's an immediate implant placement on a canine that we're gonna see later on during this webinar. So I said it already a lot of time that the white and the pink this correlation is really important. That the implant aesthetic, especially in the aesthetic area, is all about the pink. And the pink is all about optimizing what is the white tooth form. So what is the pink is about optimizing our technician work. So we have to cooperate with the soft tissue and with technician and with our technician in order to have the best result, in order to try to achieve the perfection. And we can see on the left, in this case, that the soft tissue thickness is really important. And it's important because we can try and we can decide which kind of abutment, which kind of material we can use on this kind of patient. And we can try to think that if we have a good soft tissue thickness, we will not have one of the biggest limitations of the immediate implant placement and loading, that is discoloration. Because in this article of Furhauser, he saw that the color of the peri-implant soft tissue matched the color of the reference tooth in no more than one third of the cases. And it's a huge number. I mean, every one patient out of 3 was having like a discomfort, a problem on the pink. And of course that we cannot call a success. We can call a survival implant, a survived implant, but we cannot call it success. And of course, this has been probably all of these patients that had problems. We did not see, we did not collect the information, we did not achieve the correct diagnosis, we did not have the correct treatment plan for the patient. So that's why the diagnosis it's really the key for success. And that's why we have always to look at the keys guide that the literatures gave us that are really important. But we have always to think biologically, and we always have to understand the relationship that we have between the hard tissue, so the bone, the soft tissue, and the tooth position, because this is critical for our aesthetic implant restoration, like it was for this patient that came in our office in 2005. Was a girl of 24 years old with an high aesthetic demand, and of course we had to look at all the diagnosis, the diagnostic keys guide, in order to give to the patient this result. And one of the main points that I want to underline that is a 6 years follow-up, so the tissue is stable. And this is one of the goals that we have to achieve, to have a stable soft tissue and a stable restoration in the mouth of the patient. So, in this case, of course, it's important the mechanics, it's important the occlusion, it's important every single detail of this. But to think biologically, it's always the key. Because if we don't think biologically, if we don't collect all the information correctly, we cannot achieve a correct diagnosis, and with the diagnostic error we can give some problems to the patient, because if we made a mistake in the aesthetic area, we are going to decrease the quality of the life of the patient. If we don't see the correct guides that the patient gave to us, we are going to end up with a case like this, in where we have a black triangle in between the two crowns. We have a soft tissue management, a connective tissue graft that has not been done properly. We have a poor crown, and so this quality of the life of the patient, the treatment planning of this patient was not correct, and the quality of the life of the patient was decreased. So in order to avoid it, we have always to think at the anatomic keys guide and at the surgical keys guide, because those make our treatment plan better. So we have to think at the periodontal biological width all the time, at which kind of biotype we have in front, at the marginal position, at the gingival margin position. We have always to look at the adjacent teeth, and we have to look at the interproximal height of bone. And at last we have always to look at the height and the width of the labial plate. So those are anatomic diagnostic key guides. But we have also some surgical keys guide that are the way we place the implant. We have always to think three-dimensional when we place the implant, not just baccolingually but also mesodistally, and why we place the implant at that height and why we place the implant in that position. And we have always to think at the type of the implant that we are using, because tapered is different from parallel, and we have always to think biologically. So our topic was also to try to was diagnostic, surgical, and restorative consideration. So in this case, we can see that we are talking about two prosthetic consideration and two surgical consideration. The smile line that sets to us the correct gingival margin, and the length of the incisor that sets for us the incisal edge, helping us in a prosthetic way. And the bone thickness and height and the gingival thickness help us from the surgical point of view. And we have always to try to combine them in order to have the best result that we can. So, talking about extraction socket classification, I think it's one of the key part of the lecture of today, because every single type of socket has a different approach, has a different treatment plan. So the main thing is to arrive at the correct type, to give the correct diagnosis to the type of the socket that we have. And we can have help always from the literature, like Dr. Tarno's article, that divides the socket in three main types. Type 1, that is the ideal for us, where the goal is the perfection, where the goal is the preservation. Our goal is always the perfection, but the goal in the type 1 is to preserve what we have, because in this case we have the bone and we have the soft tissue. In type 2, we don't have the bone, but we still have the soft tissue. And in type 3, that is the most challenging one to treat, we don't have neither the bone and neither the soft tissue. And our goal when we approach one of these sockets is try to bring the type 2 and the type 3 back to a type 1 and then place the implant. So we have to simplify our way of thinking, and we have to achieve the correct diagnosis and then bring the type 2 and the type 3 to a type 1 and then work from there. So in this case that came in 2006, we have a patient that was under orthodontic treatment, 24 years old, average height smile line. So we were already looking at her, and Her chief complaint was that she was wearing the bracket for several years in order to bring in the arch the two canines, but once that finally she managed to have one of the two canines in the arch, we took an X-ray and we saw that there was like an external resorption. So we went on the diagnosis part and we saw that there was a thick biotype. We started to evaluate the gingival level. We started to evaluate the interdental height of bone. We started to probe, do a bone sounding in order to evaluate where was the buccal plate. And we were thinking also of the distance of the bone from the alveolar crest. So we were collecting all the information that guide us to the treatment plan. That in this case we thought that was a type 1 with the thick biotype, and so it has been like taken out the tooth in the more atraumatic way that is possible, because as I was saying before, type 1 is the ideal. So we have everything and we have to preserve everything that we have. After the extraction, we desepithelialize the sulcular epithelium, and then the implant is placed. Always looking tridimensional, always looking mesolingually, but always looking baccolingually, but always also mesodistally. And why 1.5 millimeters from each of the tooth? That's really important, and we're going to talk about it later. Then we work on the emergence profile of the provisional. We undercontour it in order to permit to the soft tissue to heal the best way it could. And in the meantime, there was also an orthodontic extrusion in order to bring all the complex, the perioligament, the bone down, and in order to try to close the papilla on the other side. So even here we were trying to think biologically. So this is the CT scan, because this patient did not have just one of the two canine done. There was also an inclusion of the other canine that of course she didn't want to bring down in the arch, and so we extracted, and we extracted the canine, and we extract also the canine that was in the arch, the baby canine that the patient had in the mouth, and we place immediately an implant. After that, the soft tissue healing on the temporary crowns, using the new materials, the characteristic of the new materials, in order using zirconia, in order to use another detail that can give us perfection and aesthetic. And at the end, we were thinking also about the occlusion, so light contact, because the canine are key teeth in the mouth of the patient, and we thought about a group function towards the limit of the functional movement. And as I was saying before, the work has to be stable during the time, and it's one of the cases that we put in our data analysis, and that has 5 years follow-up. And here we can see also the X-rays, so the black and white aesthetic. That is always important to double check. This is another kind of patient that came recently, and was a different situation because we had to approach a thin biotype. But during our bone sounding, we saw that there was we saw and we thought that could have been a type 1. So we start to treatment plan the patient. We thought about placing the implant, then placing a bone graft, then placing also a connective tissue graft, and we will explain why, and then placing the temporary immediately. So we were collecting all our information. We were looking at the interdental height of bone, thanks to the bone sounding, and after the extraction of the tooth, we were evaluating where the buccal bone was and how width our socket was. So we decided to try to overbuild the site, because we were thinking that we were in thin biotype, and we were thinking that overbuilding this side would have been a good idea. And that's why we did it has been done a connective tissue graft. And I want, even when we do the connective tissue graft, we try to give the less arm to the patient. So we try to be the more conservative we can. So even during the follow-up, the patient doesn't have a lot of pain. And we do an envelope technique, like leaving the periosteum in the socket, so doing a partial thickness, and then placing our connective tissue graft, our tissue in the socket. Doing like this, as I was saying before, we leave the periosteum in the socket and we don't compromise the blood supply. That is really important for the final result. And here it's like a detail of what we achieve in overbuilding this site. After that, we place a kneading abutment in the patient mouth, and we compact some bone graft. In this case is porous. We always try to use small particle, and we try to compact. And on the right picture you can see the overbuilding of this site that we think that can be an important thing to do to the patient, especially with thin biotype. After that, we worked on the temporary. We start like shaping the temp, and even the shaping of the temporary, it seems that is not important, but it's a detail that it's really important, because in order to provide an excellent soft tissue support to our socket, we have to think about how to shape our temporary, and we have a critical contour and a subcritical contour. The subcritical one is the one that is staying underneath the tissue, and is the one that has to leave space for the tissue to grow back. And the critical contour is the one that is the emergence profile, and it's really important because, as I was saying before, has to provide the support for our soft tissue, and the soft tissue is the pink. So, and the pink is aesthetic. So we have always to think about it. And one of the things that we always have to think is that the temporary has to be as clean as we can, as polished as we can, as smooth as we can, because in this way the epithelium, that is really one of the main help for us in the patient's mouth, with the fibers of the epithelium, can attach to the temporary and can help us in our final result. And this is the follow-up at 2 weeks of this patient that we just did 3 weeks ago, in where was a type 1 thick biotype, and we decided to do the immediate implant, to place the bone graft, to place the graft, overbuilding the site, and then placing the temporary. Why we did that? Because we know from the literature, again, that the biotype thickness is one of the key. And we have to know that the thinner the soft tissue is, we have to anticipate an apical movement of the facial gingival margin. And in order to prevent it, as Kant is saying, we have to increase the thickness of this biotype. And Kant in 2003 published this article in where he was underlining the mid-facial changes in the socket in the mouth of our patient, and we saw that the thick biotype was, of course, a little bit more than the thin biotype. So why not to try to increase it, overbuild it, in order to have more dimensional success and more color stability for our patient? And so that's what exactly Dr. Khan saw it in 2011. And he published an article in where he's talking about that converting the biotype around both natural teeth and implant with a connective tissue graft, it seems and it appears to be efficient and to be more resistant to recession for the implant. So in order to summarize this first part, we saw that every single detail is important. So we have some criteria that we always have to follow when we are doing this kind of approach. So we saw that the case selection is extremely important. that we have to try to give the less harm to the patient during the extraction, because we can be in a type 1 socket, but during the extraction we can like break the buccal plate. And so we have to be careful also during the extraction, maybe sectioning the tooth, buccolingually, as Dr. Tarno says, in order to avoid to break the buccal plate. Of course, the implant position is important. Achieve an implant, achieve the primary stability. It's really important. And then we will see later on all of these criteria: non-occlusion loading of the temporarization, proper contour of the restoration, as we talked before, and of course we have to have our patient to help us. So patient compliance is really one of the key, because we can do everything perfect, but if the patient goes home and bite an apple with the central incisor, we cannot do nothing. So as I was saying before, diagnosis of the socket is the key. So in this case, we have a type 2. We think that we are in front of a type 2 patient. And as I was saying before, a type 2 patient is usually has no buccal plate. We have the soft tissue, but not the bone. So we have to think on what we can do for this patient. And there are several approaches that we can choose in this area. But the important thing is that we have to know that we are in a type 2 in order to take the correct decision, in order to take the correct approach. And one of the approaches that you can take in a type 2 socket is the socket preservation. And there are different ways of doing the socket preservation. But again, it's important to know when to do it, because it's important to see and to know which kind of thickness our buccal plate has, in order to really take the best decision for our patient. So, as I was saying, one of the options that we have is the socket preservation, and there are several kinds of socket preservation. In this case, it has been performed an ice cream cone technique that has been described from Dr. Tarno, and as we always try to do, using the periotomo for like cutting the fibers in order to have a less traumatic extraction as possible, using a flapless technique. So do not open the flap, leave the blood supply intact, don't touch the periosteum. Then, after that we extract the tooth, we have to clean really well the socket, debride it as much as we can, and then shape and prepare the membrane. That this kind of membrane, that is a Biomed extend from Zimmer, it has a shape that is an ice cream cone. So that's why the name of ice cream cone technique. After that, we put the membrane and we start packing the material. Usually we can use puros, we can use bios, we can do a mix of both of this. But the important thing is to use more particles, because using big particles maybe can leave some void at the inside of the socket that are not good. So we are trying to have small particles and we try to compact them. After that, we close the socket that has been grafted with the membrane. With the bride, we take out all the extra bone graft around the site, and we do our suture, that usually we can be 2 or 3 suture points. And we can suture the membrane to the soft tissue. Usually, after we can re-enter after 4 or 6 months. It's a big mistake to enter after that we did the socket preservation just only after 2 months, because we have to think biologically, and so we have to give the time to the bone that we packed to be inside the socket and to remodel with the bone inside the socket. So there is we have not to be like impatient. We have to be patient and wait from 4 to 6 months, and then we can re-enter. And like in this case, if we can leave the papilla alone, if we can do not disturb the papilla, it can be a good idea. And so we can do a papilla saving incision, and then we can go and we can see inside the socket how much we preserved, how much we have, and then decide what to do from here. As I was saying before, this is one of the approaches that you can have with the socket preservation, and is the ice cream cone from the Tarnus group. And it's coming out in 2011, this article, that is a case series of 9 cases in where it has been analyzed the bacolingual dimensional change using the ice cream cone technique. And there was a comparative study between CT scan and casts, and they saw that they have as a mean shrinkage of the buccal plate of the socket of 1.36 millimeters. That it's far away from the 4.3, from the 5.9 that we were seeing at the beginning of this webinar, like in Schraub's article. So we have like 4 millimeters of gain of this. And here there is the comparative data with the CT scan and the cast. Another article that is important in the literature, and as I was saying, there are different kind of socket preservation, different techniques of doing a socket preservation. And this is exactly what the Jung did. He did a study in order to evaluate the remodeling of the alveolar bone after the extraction with different techniques of socket preservation. So he took 40 patients, and 40 patients that, of course, they needed at least one upper of lower front tooth or lower premolar. There was no acute infection present in the site, and that this was one of the things that he was looking at it, and one of the key of this article, that the buccal bone lamina covers at least the 50% of the root. So this can tell us that we were in front of a type 2 socket. And of course, there was bleeding on probing less than 20% and an healthy site. So immediately after the extraction and 6 months after, they were taking impression in order to evaluate the soft tissue, and of course a combined CT scan in order to perform how was the hard tissue measurements. And so there were 4 different kind of treatment that these patients were given, and there was of course a spontaneous healing. There was some a grafting of bone, some different techniques with different material, even using a punch technique, so using also soft tissue. And all of this approach, all of this technique showed that there was a clear trend towards a significantly less volume changes 6 months after the extraction than not doing nothing. So that was really important. But in any case, none of this technique was able to preserve entirely the buccal plate. And of course, in this topic, it's really important to look also forward and to do other research in order to evaluate again the bone, the soft tissue, and have a long-term follow-up. Here we are in front of another patient of us that came in 2007, and that is it seems to be to us another type 2. And we did not do the socket preservation in this case. We choose another approach that can be the type 2 of Hammerle, as we were saying before. So it can be an early delayed approach. So the tooth has been extracted. We waited 4 or 6 weeks after the extraction, and then we re-entered. But before re-entering, of course, we evaluate everything. We collect all the information. We try to make sure that we were in the correct path. So we evaluate the bone height and width, the soft tissue, and then we took our decision. And the incision in this case was not a papilla sieving incision, but was a remote intrasulcular incision. Of course, after that the flap was elevated, it has been done a buccal plate evaluation using a surgical guide in order to help us. We start doing the osteotomy. and then an implant 3.7 for 13 millimeter has been placed. After that, we took our picture, we look of occlusally, and we think about what to do. And we thought that a GBR, so a guided bone regeneration, a bone graft augmentation, was correct to do in this case. And in this case, even here, we use, I think, BIOS and a membrane on top of it. And we tried even here to overbuild the side in order to prevent the resorption. Important, also the surgical technique, it's important. Every detail is important for achieve the aesthetic. And releasing the flap, so giving the flap no tension during the closure, during the suture, it's really important. Here is the suture, frontal view, occlusal view. Here we have, again, the flap releasing, and here we have the provisional. We spend time on the provisional. We look at the patient mouth, we take some pictures, we see how is the phonetics with the new provisional. So we try to think about every detail, about to increase the quality of life of the patient and to spend time during the provisional because it's important. And after 6 months, we reevaluate the patient, we reevaluate the site, and we did the second stage that with the roll flap in order to overbuild again a little bit the site in order to achieve more soft tissue. Then, after 1 month, we are ready to take the impression for the provisional. That has to be our key for the final restoration, our template for our final restoration. So we place the temporary, we look at it, and we see that it's good, and then we can take soft tissue impression in order to have another detail to give to our technician. We can take also a digital impression in order to give all the things that our technician can use and can work for the best result. And then at the day of the cementation, even here it's important, the details, it's important to place a cord around the abutment in order to make our life easier while we are gonna take out the cement, and in order to not leave some cement in the area. And if everything is done correctly, we can have a follow-up of 4 years, and we can see that the result is stable. The soft tissue is stable, the pink and the white aesthetic are getting along together. And this is another approach that is possible to have on a type 2 socket. We already saw two or three different approaches, and this is an approach that is more like difficult, and it's more risky, of course, because in this case, in a type 2, we are gonna do an immediate implant placement. But why we arrived to this conclusion? Because there was like crowns on the adjacent teeth, so would have been difficult or almost impossible to give something fixed to the patient. So in this case, we decide, in order also to talking with the patient, we decided to go on with the immediate implant placement and loading. So again, we did all the evaluation. We tried to extract the tooth with less arm for the buccal plate. It has been done a frenectomy before releasing the flap in order to have a better free tension flap. Then, in this case, a papilla sieving incision has been done, and we can see that the buccal plate was not so intact, and the thickness of the buccal plate was not so nice for us and for the patient. So what has been decided? We placed the implant. The implant has been placed, And after that, a guided bone regeneration has been done. Overbuilding, even in this case. And even in this case, spending time on the temporary, spending time on the provisional, spending time on the contour of the provisional in order to try to gain as much as we can and to try to work on the soft tissue as much as we can. And this is our temporary 2 weeks after the extraction and the surgery, and this is our patient smile with the provisional. 4 months later, from 4 to 6 months later, we can start to sculpt the tissue. We can start to look at our temporary. We can start to look at our soft tissue tunnel, and we can start finishing up the case, looking at every details, even here. And again, we use on the right picture, again, while we were cementing the final restoration, the cord in order to take out the cement, because if we leave the cement inside of the socket, inside of the tissue, we are gonna maybe lose something, maybe have some inflammation, and we don't want it because we work so hard for enhancing the soft tissue with the temp and with the surgery that it would be a pity not to take this in consideration. And even here, we have a follow-up of 4 years, and we can see that everything is stable. We can see from on the profile picture that the emergence profile of the crown has been done properly, and we can have like white and aesthetic, white and pink, and we can integrate our crown perfectly in the patient's mouth. And so we saw different approaches for the type 2. And now we have this case of a patient that is 44 years old. They came in 2007, and while we were collecting our information, we saw that there was no buccal plate, we saw that there was a soft tissue deficiency, there was like interdental height of bone that was deficiency, and so we thought that we were in front of a type 3 that is one of the most challenging to treat for us and for the patient. So everything is been like collected, everything has been studied, the proportion of the teeth, and we also thought about one of the approaches that we could have done to this patient, that was the forced eruption, bringing down the number 9 and number 10 in order to bring down all the complex of the perioligament of the bone in the papilla between the number 9 and number 10. But unfortunately, the patient didn't want to go through it. But we have always to think that the orthodontic extraction can be one of a good solution, especially in this kind of patient, to achieve perfection. Because even if you do everything perfect, we already know that in that area, because we think biologically, we cannot achieve the perfect papilla. We already know, and we have to tell to the patient this. So we extract the tooth, and again we decided for an early delayed approach. We sculpt the tissue with the temporary, and after that there was the surgery, the day of the surgery, in where we place the implant, in where it has been done a guided bone regeneration, so bone, in this case porous, and a membrane on top of it. And after that, again, all the details are important, so releasing the flap correctly, again the frenectomy that has been done in order to have a free tension of the flap, and the suture. And as I was saying, every detail is important, so even during the prosthetic part, we have to think about what we are doing. We have to look at every details, because we saw that in the surgical part, we looked at every details, but also on the prosthetic part, we have to look at it. So using a customized impression copying in order to give the good soft tissue anatomy to our lab, in order to give our technician the best that he can work with. And even here, in this case, we use a zirconia abutment because we thought that using the characteristic, the properties of this material was important for us and for the final result of the patient. And after that we gave all the information, all the pictures, everything that we can to our technician. We can have our final crown, and if the technician does his job, we can, and all the team does his job, we can bring a patient from this picture on the left to this picture on the right. But of course, as I was saying before, between 9 and 10, we don't have the papilla as much as we could have had the papilla if we would have done the forced eruption. But the important thing is that we explain to the patient, and then it's the patient that has to decide. So, in order to conclude this part of the presentation, it's important that we have to think in two different ways. When we have an intact socket, our efforts should be directed to the preservation of the alveolar walls. So we have to be careful with extraction of the tooth, and we have to be careful with the management of the soft tissue, and we have to be careful with the implant placement. But when we don't have an intact socket, all our efforts should be directed first to restore it in an adequate way socket, and then placing the implant, and then going through our whole prosthetic part. So as I was saying at the beginning of this section, it's important to bring a type 2 or a type 3 back to a type 1. And here we have an overview, again, of the three different types. And one of the key rules that we can use is that if we want to be in the safe zone, when we don't have the buccal plate, we should not place the implant. And just in rare case, in where the skill of the clinician is really high, we can try to risk something, as we saw in the case 5 minutes ago. But we have always to explain to the patient why we are doing it. And apart from the buccal bone, we have always to think about the soft tissue, and we have always to think about how can we manage the soft tissue aesthetic, how can we manage to achieve the perfect pink aesthetic. So as we were saying before, we talk about orthodontic extrusion, we talk about using of bone graft in order to give better stability, volume, and contours rather than autogenous bone. We were talking about doing some connective tissue graft or some roll flap at the stage 2 in order to give a correct dimension at the transmucosal connection. We can use we can try to avoid to connect and disconnect the components as much as we can, because it has been seen, and we will see it later, that it could be also that one detail that we have to take in consideration. And of course, spending time on the provisional, it's really important, because all the chairside time that we give to the patient in that day, we are going to save it in like 2 years, 3 years after, trying to fix what we did not do correctly. Talking about in a more literature way, I'm going to talk about some data analysis that we did in our office. And we managed to write this article, also thanks to Dr. Maurice Salama, that helped us on printing, editing, and doing this article. And the aim of this study was to see what was the answer of the hard and the soft tissue in the immediate implant placement and loading in the fresh extraction socket. So we took 20 patients in need of extraction, and we gave some strict following criteria that has to be followed. And the more important were, of course, flapless surgery, because we don't want to harm the blood supply of the socket, a thick biotype, and in this case we did not place the graft in the gap, because even this, to placing the graft in the gap, is one of the big controversies that are going on right now in the literature. So what we did, we take the time zero, so prior to the extraction of the tooth, and we did some evaluation of the soft tissue. In this case, we took as a reference point number 8 and number 10, and we saw it. And the most important thing is that the level of the gingival margin number 8 and number 10 was not changing during the study. In while we were like doing this evaluation between the prior extraction, during the temporization, and we were looking at the soft tissue answer of this. And after 3 months, when we placed the final crown, we did this evaluation again, and we saw that if we do everything correctly, we can achieve a nice result, but we can also predict a little bit where the soft tissue is going to be, because we know that in this case, in particular in this case, the gingival margin of number 9 was less than number 8. But we knew that if we would have done everything correctly, we would have managed to have apical gingival portion at the same level. And we evaluated the papilla, the soft tissue, we evaluate everything. So I'm going to present some of the results that we have. As we saw here, the average follow-up was 32 months, and of course was like not a lot of implants, were just 20 implants, but we managed to have a survival rate and a success rate in this case of 100%. And we look into the gap, because in this case we did not place the graft in the gap, and we evaluate this, we measure it, we saw that the average of our patient's gap was like 1.6, and we decided not to place any graft, because we know now that is between the implant and the bone, no matter what is the gap, is going to form bone. And so after the soft tissue evaluation, we had the hard, so we took our x-rays in a standardized way. We enlarged the x-rays in order to do the evaluation. Our referring point in this case was the interface between the rough and the smooth surface, and we were evaluating how much was the bone changing. And here we evaluate, of course, the mesial bone level and the distal bone level. I put in the lecture, in this webinar, our data that are like important, because we have to look at the changing of the hard and soft tissue that, especially for us, were like at the beginning, in the first 3 months of our treatment time. And we had this because, of course, the bone remodels at the beginning, immediately after the extraction. And is this period in where we have the more changes. And we also gave a questionnaire to the patient in order to ask them their aesthetic satisfaction. And the result that came out was a 93%. And our data, we compared our data to the data of the literature, and we see that our data were like in the same range of this. And of course, in the literature you can find different kind of articles, different kind of procedures, and you have always to look carefully at the literature, and you have to have a critical eye and a critical approach when you look into an article. And you have to see which kind of different clinical procedures it has been done in that kind of article, where it has been done, and how it has been measured. And we see here we have articles in where graft were placed and articles in where graft was not placed. So we tried to compare our data analysis to this, and we saw that our data are in the range of this. And we can see that the mid-facial recession is 1 millimeter, 0.5 millimeter. That is exactly what we had. So our result, we can conclude in our study, we concluded that the immediate restoration of a single implant can be a valuable therapeutic option in the aesthetic area, but is a very case selective technique and clinician sensitive, because again we pointed out that the correct diagnosis is the key of the final success. And of course, as I was saying before, the literature is moving forward, is always looking forward, so further research has to be done in order to evaluate the bone tissue remodeling and to obtain long-term results. And I just want to present one of the cases that was inside the article. This patient, 32 years old, came in the office in 2006, eye smiling, so already we were like a little bit worried, because it's easier in a patient with an eye smiling to give her an headache. Fortunately, there was a thick biotype, so we started to evaluate again all the diagnostic keys guide that we always look at it, and we thought that we were in a type 1 socket, and we placed the implant. Of course, the position of the implant, it's really important. The tridimensional position of it, it's really important. We have to achieve the correct implant stability, because we can be really good on doing the diagnosis. We can have our temporary ready in the chair, but if we don't achieve the primary stability, we cannot load immediately the implant. So there are some details that has to be looked and has to be think while we are placing the implant, like undersizing the osteotomy, not using the countersink, thinking of the implant, the design of the implant. So try to take a tapered design of implant in order to achieve more stability. And as I was saying before, the placement, the tridimensional placement of the implant, it's important. So I was saying, of course, we know that we have to place the implant more lingually, so in order not to give any arms to the buccal plate. But it's not just the buccal-lingual dimension, that is important to think. It's really to think about. It's important also the mesiodistal dimension, to look at it. And as we know by all the articles in the literature, that if we want to be in the safe zone, we have to have at least 1.5 millimeters of distance between the two teeth in order to ensure an adequate width of the buccal bone and have a stable mucosa everywhere in the tridimensional way. And then again the temporization, again thinking about the subcritical part and the critical fact. So in this case you can see how much the subcritical brought down the soft tissue, that after that we could have worked on it. And another detail that is very important is that when we place the temp, that day we have to look carefully at the occlusion, and we have to clear up the occlusion of this temporary. We have to explain to the patient carefully what she or he has to do, not to bite on it, not to eat on it. And the occlusion is important not just only at the beginning of our treatment, so immediately after the placement of the implant, but it's important in order to have a follow-up. It's important to have a stable result at the end of the case. And so it's important to look back at the literature even in this case, and it's important to see what does Kim in 2005 told us, saying that basically the principles of occlusion on implants are mostly based on the same principle of occlusion on teeth, but mostly based, not based. So we have to see what are the differences, and we have to know them, because even the occlusion is a detail. And if you want to achieve the perfect result that we can achieve, we have to think also to this detail. And when we are talking about occlusion on a single implant tooth, we have to think in order to minimize the occlusal forces on the implant and to distribute mostly the forces on the adjacent natural teeth. So in order to protect our implant, in order to protect our work, that's really important, because it's not important what we gave at the patient at the day of the cementation, but it's important when the patient came after 3, 4, 5, and 6 years and everything is there and everything is stable. So in this in this case we have a 5 years follow-up in a patient that we just placed the implant and we placed the temporary, we placed the provisional. We did not graft neither with bone and neither with soft tissue. But we think that we could have done it because we were in front of a type 1 with a thick biotype. So in conclusion of all this webinar, I want to give some future consideration, some future thing that maybe can help us on getting even better in this topic, and some take-home message in order to overview all the lecture. So the future consideration that we have to think, and these topics are already not even more future, but are even present, because the question to place a graft into the gap that keep height and width even if bone remodels, if one of the hottest topic and one of the most controversial one in this kind of site. And does the platform switching, this particular shape of the abutment implant connection, aid in preventing our recession, the mid-facial recession that we saw that it's one of the main problem, one of the limitation of this approach. Does placing a full contour provisional or a custom healing abutment allow us in order to have a better mid-facial contour? This is another thing that is being discussed right now. And does removing the abutment affect the tissue height? Even this has been discussed in the literature. It has been discussed even now, and it can be one of the future considerations that can help us in order to achieve even more perfection. And thanks to Guido Sarnachiaro, that is a good friend of mine that works in Dr. Tarno's office, I can show this dual zone socket management thanks to Team New York and Team Atlanta that are doing this study. And because we always thought at the beginning, 5 years ago, that the bone was the key of this. But we don't have to consider it, as I said in all my webinar, we don't have to consider just the bone zone, but we have to consider, and a lot, the tissue zone. And both of them has different variables that can, different details that we have to look at it in order to achieve the perfection. And we can see here that, as I was saying, that it's not just all about the bone, but as I said, it's a lot also about the soft tissue. And that's why we overbuilt, that's why we have to manage the soft tissue as much careful as we can. So as I was saying, all the details are important. And so we have the bone zone variables that are a lot. We have to think, as I said, of the thickness of the buccal plate, at the thickness of the soft tissue, at the size of the gap. We just talked about it. When I have to place a graft, I have to graft if the gap is more than 2 millimeters. I have to graft if the gap is more than 4. What do I have to do? I have to think about it, and I have to think biologically. And in order to think biologically, I have to think on which kind of graft placing in the socket. I have to think not to do a flap, because if I open a flap, I'm gonna destroy the blood supply of my socket, and I'm gonna have more resorption, and I'm gonna have less aesthetic. I have to think if I have to use an implant that is platform switch or not, and we're gonna talk in a while about it. We have to think, as I was just saying, of the tridimensional position of the implant. And all these variables are also good for the tissue zone. So, which kind of provisional we place? We should place a screw retain or a cement retain. we should use a custom or a stock. Is there any difference if I'm in a thick or in a thin tissue biotype? Is it different? Is there any difference if I misplace the implant? How if I change 5 times the abutment? What kind of subgingival contour I have to use? Which kind of texture has to have this abutment? So these are all variables, are all details that we have to think. So it's not just placing one implant, it's just thinking of all of these variables in order to achieve the best result that we can give to the patient. And thanks to one of my faculty, Dr. Cho in NYU, I can show this picture and I can explain what is a platform switching implant that is just placing a smaller diameter abutment in a larger diameter implant seating surface. And it seems that is not a future. Is not a future. I mean, the platform switching, the literature is saying that is here to stay. It's something that really can help us on having more predictable results. And we can see as I was saying, like the review of the literature of Ibrahim and Anterior, that they are saying that the platform switch may preserve the inter-implant bone height and the soft tissue levels. And the degree of the marginal bone resorption is inversely related to the extent of the implant abutment mismatch. Because in this case, we have to think that even around the implants we have a biological width, and not just around tooth. And just like placing the distance remains the same, but with a smaller diameter we can achieve more space, and so we can give more space to the horizontal biological width, implant biological width. And this, it's an important thing for the bone, but also for the soft tissue. And also Canullo, in his last article in 2010, is saying the same thing, that the marginal bone levels were even better maintained with increasing of the implant abutment mismatch. And that was easy to understand, because the more you put inside the abutment, the more space you gain for the horizontal implant biological width. And Dr. Tarno and this group is explaining exactly this thing. We have to think that we have an horizontal biological width, we have to think that we have a vertical biological width, and we have to think that the platform switching is helping us in preserving the bone. And preserving the bone, we preserve the soft tissue. So in this article it has been concluded we had less bone resorption in both the vertical and horizontal direction, and that the biological width around the platform switch implant was located more coronally than in the one non-platform switched. And then another topic that has been studied, and another question that we have to ask ourselves, does removing the abutment affect the tissue height? And it has been proved that it can be, especially at the first time. Especially the first time, because I was saying the epithelium, the fibers of the epithelium can attach to this connection. And every time we're going to unscrew the abutment, we break this seal. And this, it seems to be effective to our final result. And in this case, with the socket shield technique, we are talking more about the future, because this technique that has been presented by Urdeler and one of my friends in NYU noticed, basically they tried to do this article, and the aim of this was to prove that just to hemisecting the tooth on the buccal side could have been like helpful for the final result of our treatment. But the main key of this is to understand what it's going to be between the implant and the hemisected tooth. And as some histologies has been done, some case on dogs has been done, some case on patient has been done, and it seems that it's possible to achieve osseointegration between the implant, and we can achieve osseointegration, we can achieve a seal between the implant and the remaining part of the tooth. And it can be concluded in this first article that retaining the buccal aspect of the root during the implant placement does not appear to interfere with osseointegration and maybe can be beneficial in preserving the buccal bone plate. But this, as I was saying before, is just something that has to be still researched on it. It has to be studied more, because we actually still don't know what exactly is happening between the tooth, the implant, and the bone. And in conclusion, I would like to give some guidelines, our guidelines, when we have a patient like this, when we have a patient that walks in the office. And what should we do if tomorrow morning a patient arrives and we have to look at his incisor, to his central incisor? We have to, first of all, we have to collect all the information in order to decide which kind of socket, which kind of type we are looking at. And the guidance that we try to explain in this webinar is that we have basically 3 types of socket, and the type 1 can be divided in 2 parts, when we have a thick biotype and when we have a thin biotype. Of course, type 1, as I said, is the ideal solution, is the ideal environment, because we have the buccal bone that is intact. And another thing that we can do on a type 1, on a thick biotype, we can place the implant immediately without releasing a flap, because we don't have to compromise the blood supply. And the result that we can expect from this approach are optimal. And of course, we have an indication for this kind of approach. A little bit different is the approach that we have when the biotype is thin. A little bit, we are trying, as you saw, we are trying to overbuild the site. We are trying to place the implant immediately, but placing the bone and placing also the connective tissue, in order to overbuild the site, in order to prevent the resorption that we know that we are going to have, and in order to work on the soft tissue, and in order to prevent one of the limitations of the immediate implant placement, that is the discoloration. And we can expect good result with this approach, and even here we have an indication for an immediate implant. As we saw, different are the thing when we talk about a type 2, because the buccal plate, the buccal bone is deficient, but we saw that we can place sometimes the implant, and we can place sometimes the implant with a guided bone regeneration, or we can do a stage approach doing a connective tissue graft, always in order to protect our work. And the results that we can expect from this are acceptable. And but as we say, the indication for the immediate implant are limited, because my idea is always, when you don't have the buccal plate, do not place the implant. But when you have the skills and you have the possibilities, and you spoke with the patient, and you have some particular patient, as we saw, you can place the implant. And at the end, the type 3, we know that we don't have the buccal plate, and the implant it's really difficult that you can place the implant immediately, because you will end up you can end up, it's not 100%, but you can end up in a failure. So it's better to use an early delayed technique or a delayed technique. And if you place an immediate implant, you won't have an acceptable result. And of course, the indication for this in this table is no. So these are our guidelines. These are our our thought that we are always try to approach, to use with the patient. So as we saw in the last hour, we talk about a lot of variables for just one implant, for just one tooth, and for just one tooth. And as I was saying at the beginning, showing a complex case like this one that we have now is not just it's not how can I say? It's not wrong to say that this is a complex case, but one single implant in the static area is a complex case too, because you have to collect all the information. You have to think how to work on the soft tissue, how to work on the white aesthetic, how to manage to interfere perfectly the white aesthetic and the pink aesthetic, because in this case that has to be, of course, a multidisciplinary treatment. We have to consider a lot of variables, but we have to think about all the variables that are in the bone zone and in the tissue zone. So if everything is being done properly, if we achieve the correct information, if we manage to arrive at the correct diagnosis, and if we manage to do a correct protocol of therapies, we can achieve this kind of result, in where the quality of the life of the patient is improved, in where the white aesthetic is interfacing in a good way with the pink aesthetic, and in where we can give a good smile back to our patient. So basically, as always, our conclusion is that on top of all the research that are being demonstrated in the literature, there is only one element that will make an important difference, that is the dental team. And it's thanks to them that we can be here and we can present all of these cases. So thanks to them, and thanks to you for your attention. Thank you.